All right, everybody. Looks like we've got 40 people. So why don't we give it just a minute or two more and then we'll get started. My name is Mark Marabella. I'm with Mountain Pacific. I work in the Partnerships for Community Health task of the Medicare Task Order 1. So that involves a lot of different work that we do here in all of our communities across our states. We're really happy you joined with us today. We're going to be talking a little bit about the work that we do. Then we're going to have a quick presentation on some of our data updates, and then we'll also be looking at transitions of care management. What do you think, Mary? Should we get started? Looks like it's slowing down a little bit. Well, there it goes again. Huh?
I think we should start, Mark.
All right, we'll get started here today. As I said, aloha, my name is Mark Marabella. I'm with Mountain Pacific. We're very happy to host our all-member call. This happens quarterly. This is a great way for us to all get together, talk about what we're doing, and share different ideas and concepts. And we're really happy you joined us today. So please, little housekeeping items, mute your microphones during the presentations that we'll have today. We'll have one from our analytics team, the other from Kathy Lewis at Alliday. Enter any of your questions in the chat box, and we'll also be using the chat box today for a couple of our polling questions. So please share your experiences with the group. Name, organization, coalition name, and location. And any activities and or updates that you'd like to share with us, please enter in there too. So we're happy to announce that we have a new CEO with Mountain Pacific. Her name is Jill Alessi. And let me look here and see if Jill made the call today. Actually, I don't see her in here, so I know she's been very busy, but I just wanted to give her a heads up if she was around, to let her know and to say hi to everyone. This was a nationwide search. We're really happy. Our previous CEO, Sarah Medley, some of you may have known, she stepped down after, 50 years, something like that. So it's really great. So we have a new CEO. It looks like Mountain Pacific is in great hands moving forward here. Is Cassie Runsabove here today? And Cassie's been busy. She's brand new. We just talked with her last week and are starting to onboard her and work our way through. The other updates that we'll have today are from our analytics team, Ray. And as I said, Alliday. So we'll get started on that in just a little bit. We want to take a pulse check first. Want to make sure that you folks realize that at our regular meetings, we want to be able to support you with all of your needs, all of our partners and all of our communities. I want to make sure that all of our member names are updated and contact information. We have them. And we're always up for recruitment. So if there are any additional or potential partners for recruitment to report, please let us know. We'll work with you on that. The other with our metrics and data, we'll talk about both of those a little bit here today. We want to identify the most important areas of focus for you and your communities. And we need coalition participation agreements for all folks who are working with us. And one of the reasons we go through these is that we want to be able to share with you the Medicare claims data that we have. And we need to have all partnerships enrolled in our coalitions to be able to share that. Our next coalition meeting for all member will be in July, on July 5th. Our 5 goals, which we're looking at here, are opioids, chronic disease management. Each one of these has a number of different subcategory groups that we're working on. Care coordination, emergency preparedness plans, and immunizations. We have a lot of great work that we've been doing. And a couple of other areas that we're being tasked with now are health equity and also culturally linguistic and appropriate services, as well as the enrollment of people who are non-clinical, referred to as links. So as we go forward today and over the remainder of this contract, we'll be adding more people to our coalitions based upon their participation. Our first polling question, yes or no? Do you have a self-managed blood pressure program? Polling question up. And we use our polling questions to help direct the services, the resources, the tools, and the time we spend on the different items. Blood pressure has been a big push with CMS. Okay. That looks like it's calmed down a little bit. All right, pretty even. 17 no, 14 yes. Okay, let's move on to our next topic. 32, 18, and 14. If you answered no, what are your barriers to starting a self-managed blood pressure program in your community? Please put your answers in chat if you would, please. Staffing, financial barriers. Absolutely, we're hearing that all the work we're doing. Lack of staff, that's probably the number one item we're hearing nationwide with all the other groups we work with too. Anybody else? Please put it in chat. Liza, staff, Jessica, staff. Yep, very common theme. Thank you all. Well, question number 3, one of the other areas we're working on is cardiac rehab, and we're finding for a number of our more rural areas, it's hard to find one within a reasonable driving distance. So how far away is the closest cardiac rehab program that you can refer people to? Is it 5 miles or less, 10 miles or less, 10 to 5, 15 miles or less, or 20 miles or more than 20 miles? Yeah. Thank you, folks, for putting your answers inside the polling question. More than 20 miles looks like one of the biggest winners right now in the poll. We realize that because of our rural areas and how remote geographically our 4 states and our areas of Guam are. We are spread out throughout the Pacific Northwest. And obviously, Alaska and Hawaii, Montana, Wyoming represent very, very geographic diverse areas. So it's either close by, it looks like, 5 miles or less, or it's a long ways away. So we sort of anticipated that. I think these gives us a good idea about how we might be able to move forward through here. Give it another couple minutes for anybody. Okay, why don't we end the poll then and we'll move on. As I said, about 37% said it was in a 5-mile range, which is great. 43% said it's more than 20 miles. Thank you all for participating in that. Okay. All right, our first data update today is from Ray. Ray Tupling is one of our great analysts here for the Mountain Pacific team. We're really happy to have him here today, and he's going to spend about 5 minutes talking about some of our recent updates. So, we're going to share anything, Ray?
Yes. Yeah, I'll share my
Okay.
screen real quick. Yeah, first of all, thank you for having me. I'm a member of the analytics team here with Mountain Pacific, and we're just going to briefly take a look at admissions and readmissions data throughout our region. So we will bring up, first we'll dive into admissions, and I'll zoom in so you can see that. So what we're looking at here is quarterly admissions across all of our 4 states. This is going to be an admissions rate.
See anything on the screen?
Oh, we don't. Oh, sorry.
Thank you.
There we go. Okay. Apologies. Last week I actually had the blue screen of death on my laptop. So this is actually the first Zoom call I've been on. It's been Teams prior to this, so my apologies. Anyways, we're looking at admissions rates here. It's admission rates per 1,000 Medicare beneficiary years. We're looking at Q1 2020 all the way to Q4 of 2022. So that's the time frame we're looking at. So we get a little bit of a brief snapshot here in the pre-COVID times. We had an admissions rate of about 34.8. Of course, we all know what happened in Q2 of 2020. And since then, we've made a bit of a recovery. But the nice thing is we're overall downward trending. In Q4 of 2022, the admissions rate was only 28.65 per 1,000 Medicare beneficiary years. So overall good news there. We'll touch on 30-day readmissions real quick. And again, same time period, Q1 of 2020, where we had a 30-day readmissions rate of about 1.8 per 1,000 beneficiary years. And it's overall downward trend. And we're currently at about 1.36 admissions per 1,000 beneficiaries. So I think it's really a testament to the work that Mountain Pacific was doing with our partners, like everyone here on this call. So it makes my job a heck of a lot easier when I can say, hey, we're doing great as far as admissions and readmissions. So that's what I've got to share so far. We'll take one more slight look into what are the diagnosis groupings behind our readmissions. So of all those readmissions we just saw over the same time period, what are the volumes looking like as far as diagnosis code groupings? And at the very top is CKD. That is far and away the most frequently occurring group of diagnosis codes that we see. And it's been relatively stable, unfortunately. We do see a little bit of a dip in Q2 of 2020. But despite the decrease in utilization associated with the COVID outbreak, utilization among those with chronic diseases is still relatively high. Same is true for diabetes. It's been pretty stable over time. So with that, things are looking good as far as admissions and readmissions, but there's still a lot of work to do with those chronic diseases. And obviously keep the pressure up with admissions and readmissions. So if anybody has any questions, feel free to either come off mute or put them in chat. For those of you who have a participation agreement, we can get you this exact data set for your specific PCH. Just reach out to your account manager that you contact most frequently and we'll get that sent over to you. With that, I will attempt to stop sharing here and hand it back.
Great. Thank you, Ray, very much. Is Jill on the call? Jill and Leslie?
Yes, I'm here. Hello.
Oh, hi, Jill. We introduced you a little bit earlier, but would you like to say hi? And
Apologies. I called in a little late. There was a little overlap with the meetings, but exciting to be here. Exciting to meet all of you and to really be part of Mountain Pacific. So great to hear what's going on and learn about the great work that's being done. Thanks, Mark.
Thank you, Jill, very much. Okay. Everybody see my screen?
Yep.
Looks good. Okay. We are thrilled to have Alidade with us today. And our presenter is Kathy Lewis. And we have worked together with her cross contract on a few different ones. Deb Anderson had introduced her to us. We're really happy to have her here today and her presentation on transitions of care management. She also has a number of resources and tools she shared with us, and we'll be passing those out to you after the meeting today. So I will stop sharing, Kathy, so you can take over from here.
Perfect. Thank you so much, Mark.
Yeah.
So my name is Kathy Lewis, and I'm with Alidade. I'm based out of Cheyenne, Wyoming. So good morning or good afternoon, depending on where you might be located. Just here to talk to you today about transitional care management. Goes a lot into what Ray was presenting on the readmit rates. There's tremendous value in performing excellent transitions of care. It's not surprising, right? That reduces the readmission rate and the patients spend less time in the hospital and more time at home with their families. Downstream benefits to society are many, including the lower total cost of care and less strain on the healthcare system, right? We've seen, COVID, the strain on the healthcare system. So keeping people out of the hospitals. The structure of the transitional care management provides an opportunity for patients to better understand their next steps in their journey to recovery, and for practices like you to best understand how you can help your patients. Why is post-hospital care so important? It's a core initiative with Alidade. 1 in 5 Medicare patients is readmitted to the hospital within 30 days of discharge. 2.6 million seniors, $26 billion. And half of those patients did not have contact with their primary care clinician after discharge. So we can really see the huge impact on the healthcare system. There are lots of failure points in the discharge process today. Failing to include the caregivers in the discharge planning, not clearly sharing goals of care and aligning those to the patient's goals, errors of omission, medication reconciliation, lack of support when the patient leaves the hospital. Those can all contribute to a readmission. As primary care clinicians, it's important that we are aware of potential problems and we proactively address these during the transition of care process. Effects of rehospitalization, right? It's not just the cost to the healthcare system. The effects of recurrent readmissions, the patients experience reductions in functional status with each hospitalization. When patients receive excellent transitional care, you lengthen the time between hospitalizations and reduce the decline. And I know this is something I saw firsthand with my mom before she passed, is just the downward spiral of those constant hospitalizations. The TCM timeline, this is a full episode of care. So this is why the process matters and collaboration within the team is essential. Without thinking about the full episode of care for your patient, you might miss key points that will work to reduce the readmission rate. And Ray would probably like to see that rate continue to go down. So it's a 30-day episode of care. Team-based care is important. A team-based workflow is the key to success. So you have to organize around everybody in the practice doing their part, from gathering the information all the way through billing and follow-up care. You have to have assigned roles within the practice for all the steps, or you'll have gaps in the process. I did provide Mark a couple of documents that will help you, depending on where you're at in your journey with transitions of care. If your practice is starting out, there's some workflow thoughts that might help you as you design that for your practice. The key attributes of an effective TCM visit. This offers you the opportunity to partner with your patients and improve their health and reduce the risk of readmission. By using warm handoffs between members of the team, quality medication reconciliation, educating patients about warning signs and when to call, and using techniques of storytelling and teach back, you can improve the efficacy of the visit and identify areas where patients might need social referrals or other services. Learning to do transitions of care with a high degree of skill results in better outcomes for the patient and a lower total cost of care. There's extra effort invested by the practice, right? I saw the poll on blood pressure, and staffing and time are certainly always issues with every practice that I work with. But if you devote the time, the extra effort, the patients benefit exponentially. Strong communication at discharge ensures you solve for the gaps in care between discharge and the TCM call that you make. By partnering with other agencies, home health agencies, you have shared goals and lower cost. You can use a TCM to solve for multiple gaps, advanced care planning, chronic care management, outstanding chronic diagnoses that you haven't addressed with the patient in the current year. So you ensure the patients receive all the service that they need to stay on the road to recovery. Two areas that are particularly difficult to coordinate are skilled nursing facility care and social resources that a patient needs post-discharge. SNF is challenging when the PCP doesn't round in the SNF and may not have regular communications about patient of care. So establishing a communication channel and a plan and seeing the patient for a visit after the discharge is really important. And it's not easy to develop that communication with the SNF. I totally recognize that. Staying in communication with the patient and their caregivers or family about discharge planning. Patient resources vary greatly from community to community, so it's important to know what's available in your area. Aunt Bertha is a resource that I know is helpful probably in more urban areas. And Unite Us is working to build networks of social services in Wyoming. So that work is starting in our communities to hopefully provide better access to you, the practice, for doing those social service referrals. These are the 4 tenets to achieving success in preventing readmission. So having a workflow to ensure the visit is scheduled, making sure you're capturing all of the discharges, and maybe even if you're more advanced in the process, leaning in and touching base with the person while they're still in the hospital and then reaching back out to them as they're discharged. So this is what success looks like for the transitions of care. This is a word I learned coming to Aledade. I had never heard it before, lanyap. It's something given as a bonus or an extra gift, so a little something extra. And that's something we always try to provide. I have found in my work with TCMs that due to a variety of factors, TCMs are frequently billed as E&M visits, and this results in a loss of revenue to the practice. So it's really important, back to one of those earlier slides, to close the loop and ensure your billers and coders are comfortable with the TCM billing requirements and actually dropping those codes on your claims. Templates in your EHR can help ensure you capture all the required information, build the correct codes. So we have 2 TCM codes. One is moderate complexity, and you have a face-to-face or telehealth visit within 14 calendar days. And the second code is the high complexity, and you have that face-to-face visit within 7 days. All of these require the 2 business day interactive contact with your patient. Back to a little transition timeline. Be alert and aware, reach in proactively, schedule the visits. Make sure you have good lines of communication with your community hospitals, that you're getting data on these admits for your patient population. Transitions to home, contacting the patient, asking them questions. Do they understand their diagnosis? Communicating to get those discharge notes. At the visit, setting goals and establishing priorities, medication reconciliation, building a care plan. And then post TCM, closing that loop, talking to the teams, checking in with the patient routinely. So that whole 30-day, we're back to that whole 30-day episode of care for the transition. Patients really value open lines of communication with their primary care provider, and note that they appreciate a call from their PCP during their hospitalization. Most patients expect you to know everything about their hospital stay and that they're in the hospital. So reaching into the hospital helps solve for those expectations and builds a bridge between the patient and the PCP. It's important, and I educate my practices to be sure to alert the primary care practice in the event of an admission. Reach out proactively to the clinicians. Let them know that they're in the hospital. We've been exploring things like wallet cards to give to the patients or caregivers that have the primary care information on it, to let the hospital know who that PCP is for that patient. The days between discharge and that in-office follow-up are key to preventing the readmission. Medication confusion, cost barriers to the new medications, social determinants of health, those all have an impact on those first few days after discharge. Having a good connection with the patient will lead to an early discovery of these problems and readmission saving interventions. I can't tell you how many times I've heard success stories when a practice reached out, connected with a patient that didn't fill their medications. They were confused about what they were supposed to take. It might have seemed clear in the hospital, but once they got home, it was confusing. And so those calls and contacts with your patient certainly make a difference to them. In a recent study by AHRQ, half of the patients interviewed had specific medical and non-medical needs at the time of discharge that had not been addressed. Patients reported feeling lost on how to obtain home care providers, transportation, housing, disability, placards, medication, and DME. Transportation was especially important need, given how much it affected access to care beyond the post-discharge follow-up visit, such as specialist appointments and pharmaceutical needs. So I know that's certainly a struggle in Wyoming and Montana, the rural markets that I cover. Transportation is difficult, and we haven't solved for that yet. Increasing or improving access to the whole team, the team in your practice, reduces barriers for patients to ask for the help they need when they need it. ensuring good resource referral and subsequent follow-up connects the dots to better patient care. I was thinking about this, preparing for this presentation. I was at a visit and I was screened for my behavioral health needs. And the person asking me those questions told me that the clinic required her to ask them. And then she didn't make eye contact with me when she was asking those questions. And these interactions aren't about checking the box. It's about really meaningful interactions with your patients, that they really make a difference in the overall experience of your patient and the outcomes for them. So it's never checking a box, it's really making that connection. And now we're circling back to where we began. It's not just one visit. It's not just billing the 99495 or 99496. It's a full 30-day episode of care when the patient is at their highest risk for readmission. Continuing the contact beyond that visit is key to preventing repeat hospitalizations. So hope you learned something during this presentation. I really want to thank you for your time. I did share some documents with Deb and Mark that I think might be helpful. And I think we can open it up if anybody has any questions. I'll stop sharing, Mark.
Yeah, there were a couple of comments. Julie Burr had talked about the Connect referral system in Montana, and Deb Anderson brought up 211 can help identify resources also.
That's great. I have not heard of the Connect referral in Montana, but 211 in Wyoming, definitely.
Julie, you want to talk about that a little bit?
Sure, yeah, thank you. I wasn't sure if if that was the right time or what, but
Yeah.
so I work at a county public health department. I'm in Helena, Montana. Connect is an online web-based referral system. It is homegrown here in Montana. The way we're set up is we are overseen at the state Department of Public Health and Human Services, and then we have about 15 regional coordinators throughout the state in similar positions like myself who do the on-the-ground work with agencies, so social service providers, medical providers, behavioral health, etc., to get them up and running on the system. HIPAA compliant system where they're able to send and receive referrals. It provides the same kind of tracking. We are able to offer this free of charge to all organizations on Connect through grants of the state. So we're Montana based. I think we are able to do a little bit of on the borders of Montana if there's a nearby provider in another state where a lot of Montanans go to. But if there's anyone on the call from Montana who wants to know more, I'm not also happy to share outside the state as well. I'll drop my contact info in the chat. And Emily knows a lot about it too, Emily Burton.
That would be great. And if you don't mind, I'll share it with my Montana practices to make sure that they connect with you.
Great, thank you. I will add mine and then I'll add the general state one. But if they come to me, I'm also happy to forward them on. So thank you.
Thanks.
Great. Super. Any other questions for Kathy?
Kathy, this is Deb. I'd be remiss if I didn't ask you to talk a little bit about getting information through the health information exchanges to notify some of the practices about admissions and readmissions.
Absolutely. I mean, that's really key to connecting, to getting the data, right? You can't do a TCM if you don't have the data. And so we try to connect with our state HIE. So we're connected to Wi-Fi in Wyoming to collect that data and push it out to our practices. You can connect directly to Wi-Fi. Big Sky in Montana is the state HIE. Have had less success in Idaho and South Dakota, but they do have state-run HIEs. That's one way to connect to get kind of all of the data in your area if the hospitals are participating in the HIE. It's been super helpful to our practices. We can't collect every discharge, and there's always hiccups, right? There's always hiccups in data, and Ray could speak to that much better than me. But you know, if somebody at the hospital enters a date wrong or does something wrong, you might end up with a discharge for an outpatient service. But it's a start, and we're collecting, we're getting that data to practices and helping them with the TCM work. So really encourage you. I mean, that's the first step in your workflow. Where are you getting data today? If so, how are you getting it? If you're not getting it, can you connect directly with your community hospital? What's going to work best for your practice? And I know for some, it's a really manual process of going into the hospital every day and pulling out those discharges for their patients. Hopefully, as time goes on, this data will become more and more automated for you. Thanks, Deb.
Thank you. Excellent, excellent review. The other thing that I know a lot of folks might be interested in is really talking about when those folks are going into the skilled nursing facilities, and what maybe our practices and providers can do to again help make sure that we're taking care of the needs, not just from the hospital to the skilled nursing, but then also skilled nursing to home.
So one of the things Wi-Fi is doing right now is working on building those connections with the SNFs around the state. That's been what I have seen with HIEs is the SNF connections has been a lower priority. So you're not really seeing those discharges. So encouraging practices to connect with the SNF where most of your patients go. And hopefully you know that where your patients are going, maybe a little more difficult in Cheyenne or some of the bigger communities, and making those connections so that you know when a patient is discharged. I think our HIEs are starting to build that connectivity now, and that's going to be helpful. And really, and this is hard, right? Staffing and time. If it wasn't for the resources, we could do all of this work and there would be no problem at all. But the same, right? I see laughing, and it's true though, right? Managing that patient. I mean, some of the things that we're doing is we're piloting, staffing up some care management specifically to SNFs that have high length of stays so that we can help our practices manage those patients. It's not about kicking them out of the SNF. It's just having that constant communication. Can the patient be safely discharged or not? And seeing if there's why the patient can't be discharged. Is it because they don't have resources at home or don't have that support? So we're just starting to dig into a lot of the work around SNF, and it's hopefully it's going to get easier.
So Julie has put some links into the chat for anybody who's interested. Are there any other questions? Okay, thank you very much, Kathy. Thank you, Deb.
Thank
Very
you
happy to have
all.
you. Yeah, good. Good. All right. Let's move along here then. One thing I wanted to also mention is we have a brand new person in Hawaii. Her name is Jolene Kageyama. And I think Jolene is on the call, and we are thrilled to have her. Can you say hi, Jill?
Hi, I was just trying to figure out how to turn on my video so you guys can get the name and face together. Can you guys hear me okay?
Yeah.
Okay.
Yes.
Okay, let's see. Hey, there I am. Hi, everyone. Aloha. So yeah, Jolene Kageyama with Mountain Pacific here in Honolulu. So I am a former nursing home administrator. So I'm excited to be a part of the Mountain Pacific team. My focus is more on the nursing home group. and helping them with their needs. And it's interesting, Kathy, you talked about how you're just starting to build relationships with the SNFs. That was one thing as a nursing home administrator, we really focused on was return to home. And we had a return to home program wherein, you know, we made sure that our residents moving out had their provider appointments with their PCPs. And then, you know, we did 24, 48, 72 hour callbacks to ensure that they got the medications they needed, that they went to their doctor's appointment, that they did their outpatient therapy. We'd follow up with them off and on throughout that first 30 days of being home to try to keep them from going back to the hospital. So I'm not sure how other nursing homes do that, but that was something that we did at the community I was at. And that, again, talking about building that relationship between the communities and the SNFs for that person. So there's a continuum of care when that resident goes back home, and ensuring they have the right tools, they have the right resources, and then they have a number to call in the event that, you know, things may not be working out just right. And a skilled nursing facility can actually bring them back in and reskill them to avoid that rehospitalization. So your presentation was really good, and I really enjoyed listening to that. And I love the add-on building that relationship with your SNFs in your communities. Thank you for having me today.
We're thrilled we have you, Jolene. Thank you very much. Okay, some upcoming events. And it looks like Mary has put a number of them in the chat itself, so you can pick them up. We have the It's Worth a Shot series. I know many of you already attend those. We have long-term care anticoagulant regulatory review and education coming up. Introduction to the REI and MDS process. Pain and opioid management series. And we have an email constant contact series that we've been working on through a newsletter. It's a monthly email with resources for patients and providers. The April edition is on cardiac rehab. Another polling question for us as we start winding down. And again, we'd like you to put your answers in chat. What have you identified as challenges to reducing 30-day readmissions? Anybody got any challenges they've identified? Long delays in home health, community support after discharge, thank you. PCP follow-up. Lack of family and community support, scheduling follow-up appointments with PCPs prior to discharge, and all the authorization that goes with that so that we can continue to have services with other community partners out in the communities we work with. Thank you all very much. References and resources, these are very similar to the ones we had last time, gang. Working with fentanyl, which is continuing to be an emerging threat. Clinical practice guidelines for opioids for pain, for prescribing, pain processing therapy, medication safety, get naloxone. And we have recently passed out to some of you, you may have seen it, still might be coming. We have a couple of culturally and linguistically appropriate services booklets from Superior Health and Comagine, but we've created one ourselves, which we've passed out through our listserv. So you may be seeing some more of information around those areas. As I said, this is a big push right now for CMS, both in health equity and also how we address health literacy and also translation. Do we have any questions for anybody? Okay, well, hearing nothing. My name is Mark Marabella, and I'm a senior account manager here. If you need anything, please send it to me or any of the account managers that you work with. We have a terrific team here in Hawaii and Montana, Wyoming, Alaska, and the Guam and Saipan areas around our states, American Samoa. All of us work together, and we're really happy to service and all the work that we do. Our next all-member meeting will be Tuesday, July 25th. We'll look forward to seeing you folks there. July 26th for our Guam and Saipan partners. Thank you all for attending today. We really appreciate all you do for our communities. If you need anything at all, please just reach out to us. Thank you very much.
Thank you, Mark.
Thanks, Mark.